Welcome to the primer on action and advocacy research here for ATTR 811 in the Doctorate in Athletic Training program. First, I just wanted to do a quick explanation about what action and advocacy research are and what it is and what it isn't. Action and advocacy research are broad terms to define a type of participatory research activity in which the researcher is closely engaged with the subjects with the end goal of quality improvement or to spark a community change. So with that, advocacy and action research is not a methodology, and each one of them together are not a methodology. They are more of an approach where we can use any type of empirical methodology as we would like, but our end goal is to change I'm sorry for that. The end goal is to change the practice of change one own's practice through quality improvement, or to spark a change at the community level through advocacy. So that's kind of what we'll look at with both action and advocacy research. So with that in mind, as we think about this, we want to keep our goals in mind, but we want to be flexible about the methods and flexible about the approach because with action and advocacy research, sometimes you have to use things or your approach has to change halfway through, or based on your individual situation, things may change and look differently. So what advocacy and action research looks like to someone may not be what it looks like to someone else next to you. However, there are some key principles that I'm going to go over right now that with both action research and advocacy research that will kind of give you an idea of what each of these are and how they're distinct from one another. And then later on in the semester, when we get into actual content areas of action and advocacy research, you'll have a chance to see how it's done. So action research actually is derived from teaching in the 1960s and 70s in secondary schools and primary schools as a way to improve a teacher's own practice in their classroom. This still holds true today, as most of the research related to quote-unquote action research is focused in teaching. And it's kind of like a meta practice, like metacognition, to think about your thinking. Action research is a meta practice. You practice your practice. You practice your clinical practice. And there are several different theories of action research, participatory research, different, I can't remember the other name of it, like a systems model of actions research. But we'll get into more of those details later on in the semester. But the key I want you to know right now for action research is that action research is founded on the idea of continuous professional improvement and nothing else. It's simply completing research in a hyperlocal setting to improve one own's practice. In our case, it would be improving one's practice in the athletic training clinic with the patients you work with. Not with the patients you're going to work with, but the patients you are currently working with. This can be expanded a little bit because as we improve, we can improve the care of our future patients as well. But it is hyper-focused on one own's individual practice and improving the patients you are currently treating. And if we look at action research, there's a cycle. And the one on the left is the official cycle, and the cycle and the spiral you can see there. And there are four key parts of action research: reflection, planning, action, and observing. And what happens is this cycle, and you can kind of see it in the spiral in the upper right-hand corner of the cycle of action research picture. It kind of continuously happens. There is no beginning, there is no end. And in this, you want to develop clear goals, adequately prepare, develop a methodology, put research into practice, observe and collect the data, reflectively critique your results, redesign the methods, put that into action, observe and collect, reflect, so on and so forth. okay? If we look at it from a different sense and a kind of a more casual sense, if we look at the right-hand side of our screen, you want to start with the current experience of your patients, right? So this is why in some of our other classes and some of the previous classes you've taken, we've talked about patient satisfaction surveys. This is why that's important, because action research is the next step beyond patient satisfaction surveys, because you have to start with the experience of your patients. And then when you have that data in front of you, you want to look at patterns based off of your results. And then once you find those patterns and you find an area of weakness, then you look at the literature, you look at some of the evidence that's out there, maybe from translational research or practice-based research, and you add that new theory in, and then you implement that into your clinical practice. Then you begin practicing those skills, those strategies, whatever that may be, and you prepare yourself to implement that. Now that may be implementing Graston. So you're learning Graston, you're practicing Graston, you're practicing how you're going to measure it, all of those things. And then you eventually want to apply that into action. And then you start that cycle all over again. You reflect on those experiences when you've implemented that new theory or that new information or that new technique. You look at your patient satisfaction surveys. You compare and contrast your patient satisfaction surveys. You compare and contrast your patient outcomes. You compare and contrast your clinician outcomes. You compare and contrast the data, and you see what happens and what tweak needs to come next. There's always room for tweaking, and it's always about with that spherical approach, it is always about improving your clinical practice, and it's always about making sure that you're providing the best care for your patients. If we look at another perspective of action research and the action research cycle, if we start out, where are we now? You can see that there are 6 steps, that it's a continuous cycle, and you think about where you're at, where you want to go, how do you get there, explore, take action, challenge yourself, trial and error. That's sometimes how clinical practice works. We've talked a lot about evidence-based practice in using the evidence in your practice, but action research really gets into some of that clinical expertise. So kind of empirically measuring your clinical expertise in order for the patients to be successful. And then again, you reflect and you implement, and then you think about where you go from here. And where are you, and how do you want to make that better? How do you want to tweak that? What are things that I could be doing different? So again, that's just a different model. And so why does this matter? I think the first thing that is really important with action-based research and action research is that as athletic trainers, we must be concerned about the continuous quality improvement of ourselves for our patients. If we become content with our own clinical practice or our own patient care, our patients will suffer. And they may not suffer in terms of, externally they may not suffer, but internally as a practitioner, sometimes you often have to ask yourself as a critically reflective practitioner, am I doing the best for my patients? Am I keeping my patients first? It really gets into that patient-centered care, and it really creates, it's more of a culture of continuous professional improvement or continuous quality improvement of patient care. And then the second part why this is important is that when we engage in this type of behavior and we engage in this type of practice or this research, if you will, it makes our practice more transparent. And transparency is a hot topic right now in healthcare. Transparency is a hot topic right now in higher education. Transparency is important because people want to know what they're spending their money on, what their value is, what are they getting for their money. And then I found this picture, the Johari window. Although it relates more to communication, I think it really has a significant. It serves as a great analogy for why action research is important. There are kind of four stages or four different windows. There's the open window where what you're doing is known to yourself and to your patients. Then there's the blind window where you don't know it yourself, but your patients see it, right? So this is kind of like, you don't know your own mistakes. This is not being self-reflective, but your patients are able to see that. Um, your patients are able to see that you're frustrated, or the patients are able to see that you are maybe not giving them the attention that they're supposed to, and you don't even recognize that because you're so busy. Um, and then there's the hidden, which is where it's known to yourself as the clinician, but it's not known to others. And when we think about this as being when you're treating a patient and you're not really sure about something, okay? And the answer isn't known to you, but you don't tell your patient that. You don't tell your patient that you don't know. Or you tell your patient, oh, everything's going to be just fine. When in the back of your mind you think, wow, they tore their ACL, or wow, there could be something serious going on. We really need to get this checked out. So that kind of gets at that lack of transparency where the practitioner is holding back information that that the patient should know. And then finally, the fourth window in this model is the unknown, and those are things that are not known to yourself or to the clinician or to the to the patients. And with this, that's kind of where that action research comes into play, because as you continually work through this spiral, right? As you work through the spiral, you start to find the unknown, and it may first become hidden, or your patients may find that, and it may be blind, and you have to ask your patients, what do you see in me? What am I doing well? What am I not doing well? And to kind of unravel or kind of move the I guess the veil off of that unknown area and trying to make that as small as possible in order to improve our patient care. So switching gears to advocacy research. Advocacy research is defined as empirical investigations of social, or in our case, professional problems by people who are deeply concerned about those problems. Okay, in athletic training, this may be stuff like third-party reimbursement. It may be professional respect. It may be advocating for the degree change. It may be advocating for NPI numbers. It may be advocating for equality. It may be advocating for anti-discrimination language. It could be any number of things. It could be advocating for quality of life. It could be advocating for life-work balance. It could be advocating for more opportunities for engagement. And when we look at the history of advocacy research, it really started in 1892 in the United States, where there was an investigation of the poverty levels in the United States. And this researcher, he essentially developed two arbitrary levels of poverty, like $482 per year in the northern states and $300 per year in the southern states. And what he did is he developed these numbers that were reasonable but weren't really evidence-based, and then found the percentage of the population that lived below the poverty level. Okay? And then from there, he had this data and found that 13% of the entire United States population in 1892 lived in poverty. And this provided him a platform for social reforms. And he took this data, and he took the data that he collected, and he was able to advocate with this chunk of empirical information to improve public health, to create a welfare system, to create a minimum wage system, to create the what we know today as paid time off or workers' compensation, and also to create pension plans for workers in the United States. These things didn't exist until 1892 or until 1904, and even then, in some industries, they weren't really law, right, across the country, and they weren't enforceable until the 19 teens. And when we get to development of the Food and Drug Administration and some of these other quality control organizations, where they start to incorporate public health, welfare, minimum wage, paid time off, pension plans, number of hours you can work in a day, number of hours that count as a full work week, 8-hour days, all of those things. And that's really where it started. And I think this is a great example of advocacy research done right. If we look at advocacy research today, we see more and more advocacy research organizations. And, to give you an example, they're all around us. The Human Rights Campaign, which is LGBTQ equality. The Think Twice Global Vaccine Institute. This is an anti-vaccine institute that does research about how vaccines are bad. The National Rifle Association, a pro-Second Amendment organization that's done research about the bias of the Center for Disease Control in terms of trying to withhold our Second Amendment rights of bear arms. And they've done this really interesting policy work, not that I necessarily agree with the premise of the National Rifle Associations, but they've done this really interesting research that essentially looks at how government institutions and government health institutions has defined gun violence as a disease, and the fact that it's viewed as that gun violence is viewed as a disease is harmful to the Second Amendment right of the Second Amendment of the Constitution. Now, I just think that's absolutely fascinating. And again, I don't necessarily have to agree with the premise of the organization, but the way they've been able to manipulate the data and utilize the data for their own advocacy, for their individual organization is just really, really fascinating. And you can really learn a lot about advocacy if you look at some of these successful organizations that are very polarizing, whatever side you stand on. And then obviously the National Athletic Trainers Association is a professional advocacy organization that we utilize every single day in our profession. But I think advocacy research cannot only be limited to organizations. Individuals can participate in advocacy research. You can advocate for your own health and well-being as a single individual. You don't have to rely on one of these larger organizations. And so, as we get into this, hopefully you'll be finding a topic and at least discussing an advocacy-based research project. Not that you'll do it, but to find something that you're passionate about and to think about how you as an individual can make a difference, whether that's at the hyper-local level, the community level, the state level, the district level, the national level, international level. All of these advocacy organizations today have a goal, but the problem with advocacy organizations and sometimes advocacy individuals is that when you have deeply concerned individuals or passionate individuals about a cause, this may cause an overstatement of the results of the empirical evidence, making things seem better or worse than they actually are. This creates a problem, particularly if you have a hot button issue where people buy in, or you have a polarizing issue where people buy in. And I think we look at a couple more recent examples, the vaccines, right? We have the whole anti-vax movement, the anti-vaxxers, in which the evidence clearly demonstrates that there are some adverse events that occur from vaccine administration. The science says there is. However, what's happened is that individuals take these incomplete bits of information and they overstate them. And now vaccines cause autism. They are the link of autism, right? It's not, an adverse reaction could be a decline in mental function during the developmental years, right? That's much different than saying vaccines cause autism, right? Another example from the 1980s was elder abuse. There was a large study where individuals in nursing homes. They found this this epidemic of elder abuse in nursing homes, and then everyone wanted to make sure they watched their parents, their grandparents when they were in um, nursing homes, and no one wanted to send their parents to nursing homes or care facilities because they were fearful of elder abuse. But that, as we did more and more and more research, the actual empirical evidence was a very small portion. Also with kidnappings, in the 1960s and 70s, there was a study that came out that said over 50,000 kids were kidnapped from their home during per year in the 1960s and 70s. This caused mass hysteria, right? Where people were afraid to let their kids hang out outside. They're afraid to, you know, be kids, right? And we even see that trickle down today, even though that's been debunked and that the statistics are much actually lower than what was reported. We see that today with even the criticism of you hear them called free range parents, where you let your kids play outside and you may be sitting inside, but they're playing in the front yard. Now that's a no-no because you're afraid that someone's going to kidnap their child. Although the statistics are very minimal and they don't necessarily support that your kid's going to be one of the 50,000 that gets kidnapped next year. That doesn't mean you don't want to take precautions, right? But it's no different than when you see an airplane crash, right? Airplanes are very safe. They're the safest form of transportation, but you see an airplane crash and then you kind of get this nervousness and like, should I be flying? Because the media covers it so much. And so that's what happens with advocacy research. We also saw this with rape and sexual abuse in children. I want to say this was happening in the late 70s, early 80s. Not that rape and sexual abuse in children is not a very serious issue. I 100% agree that it was a very serious issue. But what happened was they collected a small sample of data and they overestimated their results. They over-exaggerated their results, which led to, this hysterical kind of point of view that everyone was a predator. And it created undue stress. Again, that was later debunked, but for a long time, and again, still today, you have to fight those those ingrained fears, which is where a lot of times advocacy research kind of gets derailed. So the bottom line is, and the trick to advocacy research, although it's easier to say than it is to do, it's to be cautious and modest about your empirical claims. So whatever your data is, you have to be cautious and modest about that. However, you need to be passionate and personal in expressing the policy views. So you need to be personal and you need to have that passion when you're talking about trying to change policy. However, when you have the data are the data. You don't want to overstate it. You don't want to understate it. You want to make sure that it's highlighted and it is what it is. But then you can make your case personally and passionately about why whatever you're advocating for or against needs to change or not change. There's going to be more to come later, but the key to advocacy research, and again, there's going to be more to come at the end of the semester, but don't complain about your conditions if you're not going to do anything to make it better. And I think that's really at the heart of advocacy research, not only at the organizational level, but also at the individual level. Oftentimes we complain about not getting paid enough, not having enough time off, working all the time, not spending time with our families, all of those things. But if we're unwilling to make it better for ourselves by advocating for ourselves or by collecting data to advocate for ourselves or by participating in the salary survey to advocate for ourselves as a profession through individual salary data, we can't complain about it. And that's really at the core of advocacy research. So with that kind of finishes the primer. I hope you're going to get excited and you're going to get excited about what we're going to do in this class. I'm really looking forward to it. There's going to be a lot of challenges and it's going to be a different class. But I think it's really going to be valuable and provide you some tools and some perspectives to make a difference in your individual clinical practice.